Okay, can you see my screen?
Yes.
Okay, so I want to thank Rich and Dr. Ponsky for inviting me to participate in this session, and to everybody who has joined us from around the world. Over the next 10, 15 minutes, I would like to discuss the growing global burden of non-communicable diseases in general, with a focus on injuries, and also highlight aspects that are relevant to pediatric trauma. So let's begin by looking at the ongoing, rather dramatic changes in health needs that are going on globally, a process that have been referred to as epidemiologic transition. In poor pre-industrial societies, infectious diseases and malnutrition have been among the major causes of morbidity and mortality. Therefore, it did make sense to focus on preventive health measures, such as vaccinations and recently the treatment of communicable diseases such as tuberculosis, malaria, and HIV. However, as we've all seen with rising economies, bringing new affluence across the world, lifestyle and behaviors are currently linked to 20 to 25% of the global burden of disease, and this proportion is actually rapidly increasing in poor countries. In low and middle income countries, where the majority of people live, NCDs such as cancer, heart disease, as well as road traffic deaths are fast replacing infectious diseases and malnutrition as the leading causes of disability and premature death. So today, less than half of deaths in the developing countries are due to NCDs. But by the year 2020, it is projected that NCDs will account for more than 70% of deaths in developing countries. Now, let's get to some basic definitions. When we talk about burden of diseases, we have to talk about DALYs. And I think everybody hopefully is familiar with the concept of DALYs, the disability adjusted life years, a metric that was first introduced in 1993 as a measure of the burden of disease. The DALY represents a single index that aggregates the total loss of health at the population level by summing up premature mortality in years of lost, YLLs, with non-fatal health outcomes in years lived with disability, that's YLDs. So the basic equation is that DALYs is a sum of YLD plus YLL. In practice, to increase the accuracy of the YLD estimates, one has to take into account the duration of disability and also factor in a disability weight. A disability weight reflects the severity of disease on a scale from 0, which is perfect health, to 1, which is equivalent to death. Also, just to point out that there has been considerable controversy about DALYs in general and whether it is the best methodology to measure burden of the surgical diseases. One of our colleagues, Steve Bickler, and his co-authors of the Disease Control Priorities 3 project have reflected on the challenge conditions. And they felt that DALY-based approaches may not be the best metric for global surgery or for measuring the impact of surgical interventions. Alternative approaches have been suggested, but it is likely that DALYs will remain the currency for allocating global health resources for a long time. So the 2013 update of the Global Burden of Disease study was just published, including these flow charts of how they estimated the YLD for injuries. They assessed both long-term disability and short-term disability, and then each is multiplied by a disability weight in order to determine the YLD. Here is the reference, which can be accessed full text online through the BMJ Open Access project. The data represented in this slide and many of the examples that are cited in this presentation are from sub-Saharan Africa. However, there are similar challenges across most of the low and middle income countries. Here you can see that injuries represented by these two sectors currently constitute less than 10% of deaths, of total deaths in sub-Saharan Africa. And here is a selection of African countries showing that the proportion of deaths from injuries is quite variable from 3% anywhere up to 9%, and generally less than 10% in all the countries, but that was in the year 2008. Now, there is new data, which we're going to come to later, but let's talk a little about the growing burden of NCDs, particularly injuries. So road traffic injuries are preventable causes of premature deaths and morbidity. And Africa currently has the highest death rate per population from road traffic injuries, with pedestrians and other vulnerable road users suffering the most. These road injuries disproportionately affect the poor, who have very limited access to emergency care and therefore tend to have worse outcomes. Now, among young men who belong to the most economically productive demographic group, road traffic injuries are second only to HIV/AIDS as the leading cause of premature death. Injuries also cause disability, which further reduce productivity and consume resources that could otherwise be used for social and economic development, and they certainly increase pressure on existing fragile health systems. In fact, by 2015, road traffic injuries are expected to be the number one killer of children aged 5 to 15 years in Africa. Yet, although funding to developing countries for NCDs has grown sixfold in the past 2 decades, it still comprises a puny less than 3% of overall global healthcare funding. Now, the good news is that much of the death and disability from injuries are avoidable through preventive measures and the availability of basic surgical care. This slide shows estimates from DCP3, that's the Disease Control Priorities 3 project, of the number of deaths per year that could be prevented if basic surgical care were available in low and middle income countries. They defined basic surgical care as having the capacity to treat 4 specific GI diseases, including familiar things like hernias and appendicitis and bowel obstruction and gallbladder disease, 4 maternal neonatal conditions, and injuries requiring simple interventions. Now, they made the assumption that surgical care could then be scaled up to match the accessibility and standard of care in high-income countries across all the sectors of the healthcare system. Now, that's a tall order, but DCP3 estimated that if we can scale up care based on these selected conditions, we will be able to prevent 3.2% of all deaths and 3.5% of all DALYs that occur each year in low and middle income countries. Now, note that the majority of preventable deaths were due to injuries. That's about 77% of all preventable deaths were injury deaths. These were followed by maternal conditions, neonatal conditions, digestive diseases, and others. Now, road injury, that's 290,000 deaths per year, and falls, 184,000 deaths per year, were the 2 most common causes of preventable death. Also, note that South Asia and Sub-Saharan Africa have the largest number of preventable deaths per year at 485,000 and 327,000. If such basic surgical care were provided, DCP3 estimated that injuries would account for the largest fraction, that's 68% of avoidable DALYs. Road injury is the leading cause of injury-related avoidable DALY in low and middle-income countries, representing $16.1 million per year, followed by fire, heat, and hot substances, which cause burns. That's about $10 million per year. Even then, the basic surgical package that I talked about earlier would only treat about 40% of the total burden of surgical diseases. But note that of the 60% that cannot easily be treated, about 84% of that were due to injuries. So that represents about $200 million per year that cannot easily be treated. Now, in this slide, the burden of disease in 2008 is represented by the yellow bars, while the red bars represent the projected burden by the year 2030. So it was projected that by the year 2030, the disease burden in Dallas for most of the communicable diseases, whether it is HIV, AIDS, or malaria, parasitic diseases, will become significantly lower. Whereas if you look at the non-communicable diseases, and that includes injuries, intentional or unintentional, and even things like neuropsychiatric disorders, they will increasingly become preeminent as contributors to the global burden of disease. However, please keep in mind that the projected burden of diseases in this slide were based on earlier data. Actually, I made these slides about 2 weeks ago, and just a couple of days ago, I found that there has been some new data that was just published. I think it was probably just last week by the Global Burden of Disease Study Group, which I'm going to show you. So here's the new data, just published just a couple of weeks ago. They updated the data up to 2013, and then they recalculated some of the earlier estimates. What they found was that globally, the burden of disease due to road injury has actually decreased significantly since 1990. And in some high-income regions, we're seeing reductions of 40, 50%. Unfortunately, the reverse trend is occurring in low and middle-income countries, particularly in sub-Saharan Africa and South Asia. Even then, the rates of increase in these poorer countries are actually slower than the earlier projections that I showed you. The increased daily rates in low and middle income countries, the increased daily rates in low and middle income countries is attributed to mostly to lack of comprehensive urban speed limit laws, seatbelt laws, motorcycle and helmets, and or drink drive laws. There is also very poor enforcement even when these laws exist. These types of laws are entrenched in most high-income countries and have been shown to substantially reduce road injury mortality and are likely responsible for the gains made in the past few decades. What is remarkable is how these projections apply to the pediatric population in low and middle-income countries. This slide shows the projected dramatic increases in the burden of injuries as a proportion of the total burden of diseases in these poor countries, particularly in sub-Saharan Africa. Again, note that these were earlier projections based on the 2008 data and might very well be revised in light of the new data that has just been published. Despite being the least motorized region of the world, sub-Saharan Africa has the highest road traffic death rates in the world, proportional to its population. The number of road traffic deaths have been predicted to rise by at least 80% by 2020. But again, the outlook may not be as bad in light of the new data. Vulnerable road users, pedestrians, cyclists, users of motorized two-wheelers constitute more than half of those killed on the roads. Now, pay attention to this stat. Vehicular occupants represent 43% of all deaths from road traffic injuries in sub-Saharan Africa. I repeat, vehicular occupants represent the largest fraction, 43% of those killed in road traffic injuries in sub-Saharan Africa. Also, note again that for young men, road traffic injuries are the second leading cause of premature death after HIV/AIDS. Now, let's briefly talk about the drivers and determinants of the increased injury deaths in low and middle income countries. These are likely related to demography, urbanization, and lifestyle changes, which are driven by rising economies, the internet, availability of new technology. Africa's population is growing rapidly enough to double within a generation. Sub-Saharan Africa is urbanizing faster than any other region, and the risk of crashes and injury increases with a poorly regulated transport sector. Many do not use seat belts. The roads are often unpaved. The vehicles and the roads are poorly maintained, and there is little monitoring or enforcement. Lifestyle changes such as harmful alcohol consumption is also a common risk factor for road traffic injuries and is expected to increase with further economic development. Africa already has the highest prevalence of heavy episodic drinking of any region in the world. So here's my final slide to support discussion on possible solutions. To prevent road traffic injuries, law enforcement needs to be combined with public awareness campaigns and education to increase seatbelt use and helmet wearing and to reduce speeding and drink driving. But also, as DCP3 has demonstrated, we cannot significantly reduce injury deaths by prevention alone. Prompt emergency care for road traffic injuries can save lives, reduce the incidence of short-term disability, and dramatically improve long-term consequences for patients and their families. Providing the capacity for basic surgical care is also an important element of the overall strategy. And the data has shown it can reduce overall rates of death and deaths by over 3%. We must also henceforth avoid funding silos and aim for broad health system strengthening. Together with other disease groups, NCDs and road traffic injuries face constraints across all the main components of health system, but solutions can be shared across programs and initiatives and be part of a wider system improvement. We also all know that weak governance impedes work to improve health system effectiveness and health outcomes generally. And with the greater emphasis on prevention and recognition that many of the solutions for NCDs and road traffic injuries lie outside of the healthcare sector, broad partnership across a range of sectors are needed. Political will, active civil society organizations, and research supports are all significant contributors to success. So in conclusion, I spoke about the epidemiologic transition that is yielding higher rates of morbidity and mortality from NCDs and road traffic injuries. But as I pointed out, hope is not lost because a lot of deaths from injuries can be prevented, both by traditional preventive measures, but also by secondary prevention by providing treatment for injuries that can be treated using a basic surgical package. And I also spoke about how advocacy and for action by governments, international agencies, NGOs, and donors can help to yield a positive outlook for injuries in low and middle income countries. Thank you.
Thank you, Ben. That was great. If you can stop sharing your screen, and then we'll start discussing. I'll just start with, obviously, it's a scary numbers. And big numbers that need work, as you've outlined. You've also outlined a bunch of options. What is there some part of that you think is the biggest opportunity, the easiest quick win? I mean, we know here in the United States there's variations, even within the United States, of restraint use and following these for both adults and children, of course. Are there thoughts on how that can be implemented, or is that the first step if you had to pick a first step, where would you start?
I think, obviously what might yield the greatest benefit, if it were possible, will be massive infrastructural provision, but that's not going to come that soon. If we can have better paved roads, that's not going to come anytime soon. So probably the quickest would be just advocacy for seatbelt laws and enforcement of seatbelt laws. You saw those pictures of people on motorcycles with all their family members without any restraints. When there is an incident, you can lose an entire family on the back of a motorcycle. So I think that's probably going to be the quickest things that advocacy groups can help to see happen.
Ben, there was a question about training globally. What is your perception on how up to speed the rest of the world is do we have do you find major disparities in certain regions of the world, and what is it that we can do to minimize those disparities?
In terms of training, we must recognize that many of the regions of the world are actually already doing a great job organizing systems of trainings somewhat similar to what we have here. Whether you are talking about in India, where they have great training systems, or in Latin America, they all have colleges of surgeons that are, similar and partners of the American College of Surgeons that we are very familiar with. So I think that, rather than trying to reinvent the wheel, there's a lot that we can actually do to create true partnerships with those training organizations. And support them either by helping them to improve the ways they train, the way they examine their residents, and also for those of us that do missions, it's nice to go and do a bunch of hernias, but I think you can achieve a lot more if, as part of your trip, you figure out a way to support local residents, and help them to improve their training systems.
Before we go on, I want to make one comment to from a tech standpoint. We have hundreds of people we can see that are logged in watching, but the rest of the audience can't see you to chat with you unless you make a comment in the chat. So just say hello, make a comment in the chat, and then your name will pop up, and then everyone can privately chat you or ask you questions specifically. Sorry, Rich.
So, no, that's great. I want to open it up to the rest of the panel to see other thoughts. That includes you, Steve, as well, and Todd, I see you on the screen if you want to ask any other thoughts on Ben's talk.
Yeah, Ben, that was great. I'm curious to know, you had a slide there about a basic surgical package. What's in that package for injury as you think about sort of broadening the scope and applying that in developing countries?
Yes, the details will vary from place to place. I think what the DCP3, the main thing that I wanted to point out was that if you could have a package that could help you through not the very complicated stuff, okay, but if you look at the bullet points on injuries, it includes things like the ability to suture, the ability to put in a chest tube, the ability to establish a surgical airway, to put in, to do a cut down, to set, fractures, just looking at just the very, very basic things that if you have the capacity to be able to do that, you will save a lot of lives. And just forget about the very complicated stuff. We're not talking neurosurgery. We're not talking we're not talking, by the way, it does include a trauma laparotomy. That's a very basic thing. But it's an operating room, it's an anesthesia machine, it's having an anesthesiologist and having some nurses who can, be part of the team. So again, the exact components will vary and the cost will vary from region to region.
There was a question from the audience. Mira Menon says, Ben, question from Mira Menon says, what types of injuries are seen in the pediatric population in sub-Saharan Africa and other African countries?
As I showed, it's still overwhelmingly, it is a lot of road traffic injuries. Unfortunately, you saw that picture of, children on the back of a motorcycle. There are a lot of pedestrian injuries, a lot of burn, actually. And, the usual, toddler falls are also fairly common.
Great. Ben, I'm just going to ask one more. Oh, go ahead. Someone had a question? Steve?
Yeah, Ben, thank you very much. A very, very interesting subject. Just in regards to the health system strengthening that you're talking about, I would assume that the majority of that strengthening needs to be in the rural areas. I mean, is there data? Do you have data as far as the differences in the treatment in a rural, urban population, sub-Saharan Africa versus the rural population? And would it need to be strengthened from the ground up, I mean, starting at the EMS levels, or are we talking more of a strengthening upon transport, et cetera? Thank you so much again.
Yeah, thanks for the question. This is obviously very complicated because we're talking about regions of the world where, the trauma systems as we know it often do not exist. In Nigeria, for example, which has 180 million people, the most populous country in Africa, there is not a single functioning trauma registry. So I think, trauma care systems as we know it simply, don't exist. And however, a lot of the population lives in urban areas or in urban shanty towns. So I think if you wanted to get the most bang for your money, you probably want to invest in creating some sort of trauma system in the large urban areas. Um, having an ambulance system, having a way to transport people from the site of injury to hospitals that have the capacity to be able to provide the basic surgical package that we talked about. So I think it's a lot. I mean, I think if you talk about the rural areas, some of these places are very, very remote, and the nearest hospital could be 10 or 20 miles away. And there is just really no quick fix to that kind of problem right now, because you need access roads, you need you need to actually have physicians and nurses who are willing to go and practice in those parts of the countries where there is no electricity and there is no running water, and a lot of the health workers are simply not going to go there. So I think in terms of what is most practicable right now, I think you have to concentrate in the large urban areas, which is where you have a lot of the road traffic injuries.
Great, thank you. Thanks, Ben. That's really useful, and I hope you're going to stick around as we go through the next few talks, because I think we hope that these will tie together. I'm going to just prompt you with a question to think about as we go through these. Given all the technology we're using today to just have this GlobalCast event, what role can technology help allow us to help better from a distance? If, we can't all be there. We can't constantly be on missions there. How can we use technology to help these countries? So as you think about that, as we go through the next talks, we'll come back to that, I think, for all of them to pull things together later. So thanks for your talk.
Thank you.